Yeah.
Okay.
Are you recording?
I paused it and then I like started again. Okay, ready?
Yep.
Hello. Today I'm joined by one of my colleagues who is a podiatrist that's based in Harborne. Tausif, say hello.
Hi, Abid. How are you?
I'm surprisingly good considering what's happening. How are you getting on with this COVID-19 pandemic? How are you finding?
I'm not doing too bad. I've been enjoying the sunshine the last few days. Kids are keeping me busy, as well as I am seeing patients on virtual consultation. So yeah, I've got plenty to do.
How are you finding that virtual consultation with patients?
It's been very helpful, especially for my musculoskeletal patients. I've just come off a call from one of the patients who had tibialis posterior tendon dysfunction, and we were able to see him doing the exercises and stuff, and I can do the plan.
Okay, let me ask you. I'm going to put you on the spot.
Okay.
Because I know you like me putting you on the spot. Name me two things that you are really missing during this COVID-19 pandemic. Two things that you ordinarily do.
Actually, two things I'm really missing. Number one is patience, that patient interaction, and number two got to be the feet.
Feet. Okay. I am missing going to the gym, and I'm missing Starbucks. Obviously, patience, but I'm missing those two things. Today, me and Tausif are going to be talking about injection treatment within podiatry. I'm not quite sure where this is going to go, which is going to be good because we like a bit of controversy, don't we, Tausif? Controversy is good. Can you see my screen?
Yep.
All right. So we're going to be talking about injection treatment within podiatry. However, we're not going to limit it to just injection treatment. We're going to be talking about a few other things as well. It's going to be a general overview rather than an in-depth course, rather. So the first thing I want us to talk about, and I think Tausif would agree with me, the Faculty of Pain Medicine, Royal College of Anaesthetists have given the following guidelines: that injections must not be undertaken in individuals with active COVID-19 infections, but the potential arises to do harm to individuals who may be incubating or later develop COVID-19 symptoms. Now, with everything, we have to have a risk to benefit ratio. I am currently not doing any injections that I would normally do, and I normally do a hell of a lot of injections. How about you, Tausif? Have you stopped all injections?
I have. I've actually closed my clinic down for. I've been closed for 3 weeks, and I'm intending to stay closed for another 3 weeks, and after that, I'll open up. So yeah, I'm not doing any injections myself, and I think I'll be reviewing these guidelines as soon as we open to see what we can and what we can't do.
So I had quite a few steroid injections booked in just before the lockdown, and I decided to cancel them because ultimately, before this guidance was released, I knew that there may be an impact with a steroid injection and COVID-19. So that just gives you an overview that we're not currently doing injections, but me and Tausif will be returning back to doing injections as well as other treatments after, hopefully, COVID-19 pandemic is over. Now, the types of injections that podiatrists offer within podiatry, I'm going to briefly go through them, and then I'm going to talk to Tausif about them. Now, the common ones are dipomedron, which is like a steroid. The other steroid within this image is Kenalog. We've also got anesthetic there, Ostenil, sodium chloride, and biotherapeutic agents. Tausif, do you tend to use dipomedron?
Looking at that picture, some of the things which I tend to use is dipomedron, bupivacaine, which is local anesthetic. I use two different ones, which are my favorite ones, and we use them in podiatry as LAs, bupivacaine and bupivacaine. One of the main reasons bupivacaine lasts a bit longer onset, but it takes it just wears off. It gives you the longer period of time that the foot stays numb. Mepivacaine, that's a bit more of a faster onset, as well as it doesn't last as long. Ostenil injection is something which I am introducing to the clinic myself, because there's some growing evidence with regards to ostenil tendons, ostenil mini for big toes, as well as ostenil injections for the knees as well. Dipamedrone is another one, which is, I suppose, in all three of them, dipamedrone is the most commonly used injection in my clinic.
I use all of those injections, including the biotherapeutic injections. The one that I don't like to use anymore is ostenil tendon. I have not, in my experience, when I've used it, I haven't found it beneficial. I think there are other options that we're going to speak about a bit later on in this presentation that I think are more suited to a tendinopathy. But this just goes to show that the wide array of options that podiatrists have within our scope. Now, I'm going to put a proviso in here. Kenalog is, we can only access if we have a patient-specific directive. So when I use Kenalog, I get an independent prescriber to prescribe it for myself, for that patient, and then we use Kenalog. However, me and Tosif are soon going to become independent prescribers because we are doing the course. Are we not, Tosif?
Of course we are.
Yes, we are. You are definitely doing with me because you're going to sit my exam.
We've both applied for the course already, haven't we?
That's right. We are looking for. I mean, that would be the next step for us. So, as you said before, we tend to use dipamedrone, which is methylprednisolone. If you can see my cursor, can you see my cursor on screen?
I can actually.
Yeah. So we tend to use methylprednisolone. There are other steroids, but that's the one that we tend to use.
I think in podiatry world, I haven't seen anybody using other much. It's dipamedrone is the go-to steroid injection for us, isn't it?
For soft tissues and ligaments, and but I find that Kenalog triamcinolone is more suited for intra-articular. So if you've got issues within a joint, it may be more suited. Sometimes I have, with a patient-specific directive, use triamcinolone for tarsal tunnel syndrome, but use a very small amount, and I've got, but it's really dependent upon the patient. We obviously, both me and you, we take a lot of history from our patients. So the most common contraindications, the reason why we wouldn't give an injection is obviously if there's an infection there, if you're allergic to drugs, if you've got trauma, recent trauma, diabetes, coagulation disorders. Is there any others that you may want to add to that, Tosif?
Blood pressure, it can actually have a short-term effect on blood pressure as well. Diabetes is fairly short-term as well. Hopefully, we give it in feet, which is very localized, and the quantities that we tend to use doesn't really have a massive effect anyway. It is the contraindication for the for steroid injection anyway.
Very true. And actually, for all of those injections that we are talking about, the main contraindication is obviously taking their like medical history to one side. If they've got psychological issues with needles, I would never try and force a patient into having an injection, because you really need the patient to be calm while they're having an injection. There are many, many other options, which we're going to speak about, me and Tosif, apart from injections. So if the patient doesn't want an injection, it's fine. We can find another option. We're going to start talking about individual conditions. Now, let me get 1 second. Come back. First MTPJ arthritis. Now, it's my little foot. This is what happens to my patients that don't pay my fees. Anyway, this is something that me and you see a lot of, don't we, Tosi?
Absolutely. I think doing rheumatology in the hospital meant that joint arthritis is something which I'm very familiar with. The osteoarthritis, the rheumatoid arthritis, gout usually affect big toe as well. So yeah, I suppose in feet, big toe joint is one of the most commonly affected joint with regards to osteo, as well as rheumatoid and stuff like that as well.
So, in your experience, how have patients responded to having an injection within this joint?
Rheumatology patients respond really well because the condition dictates the inflammation of the joints anyway. They respond really, really well. Mild to moderate sort of osteoarthritis patients respond really well to a steroid injection as well. The Ostenil Mini, you talked about Ostenil, you're not a big fan of Ostenil tendon injections. Now, I haven't done many for me to kind of talk about from the personal experience point of view. However, to what I actually read up on is that if you use ultrasound guided injection and you get it right to where you want it, you need to get it to, the efficacy improves. But I suppose that's like with anything, isn't it?
I mean, okay, first of all, I'm sure Tosif would agree, this wouldn't be our first line of treatment, as with anything. So we would be looking at, I would be looking at footwear advice, maybe a modification of activities. And if the patient's a runner, I would definitely try and get them into halters and try and get them some orthotics. However, all of that being said, I think there is a place for injection treatment for first NTPJ problems. You mentioned gout, definitely. I tend to aspirate first and then inject. I use Ostenil Mini, and I love Ostenil Mini for first NTPJ joint injections, and Depomedron, obviously. I'm sure we both use ultrasound guided, which is great because it basically enables us to hit the spot. I'm not going to go into detail about the injection, but we do use quite a fine needle for this.
I think steroid as well. Ostenil, I don't know about which gauge needle that you use, but I generally tend to go with fairly finer needle and take my time injecting.
I mean, you can see that on the right-hand side of the screen via ultrasound, you can actually get right into the spot. And it can give patients 12 to 18 months of pain-free activities. One of the things that I'm often asked is, how long is this injection going to last? And it's really strange that how you can put a time limit on it. So some patients can go 12 to 18 months and they can play golf, football, or whatever else they need to do, and they maybe need a top-up injection. Some people only need one injection because they might do rehab, they might use orthotics, and they might have a change of footwear, and they may not need further injections. Have you found the same thing, Tosif?
Yeah, I think how long it will last is very individual to the patients. For some patients, it might not benefit them, or it might not last for a very long period of time. For some people, that's it. They just need one injection and they're absolutely fine. In a year, steroid injections, you can have like 2, 3, possibly 4 pushing it in a year.
I generally don't do more than 2 in a year, but I mean, you can. I've seen other.
My magic number is around 3, depending on the symptoms and what we're actually presented with, especially with the rheumatoid arthritis. It just changes that a little bit because it's an inflammatory condition, and hence why you're not going to cure it with an injection. All you're trying to do is just maintain the symptoms and manage the symptoms. Ostenil Mini, I like to do Ostenil as like 3 single injections to start off with, and then as a top up, I'd probably use Ostenil Mini Plus. But I have started injecting Ostenil Mini Plus as a first line therapy as well.
So it's quite strange, you know, well, it's quite interesting, rather, because we're both practitioners and we're both very experienced. And we both have different protocols. So I tend not to do a series of injections. I'll tend to do a series, like a single injection. However, both protocols can be highly effective. Is really dependent upon the individual practitioner. I'm going to move on to Mortons Neuroma now. Proceed. First of all, explain to our viewers what kind of symptoms will a patient get with Mortons Neuroma?
It's a typical nerve-related problem. So tingling, numbing, sharp shooting pains are quite evident and quite prominent in Mortons Neuroma. Tight shoes elicit the symptoms. Activities can actually elicit the symptoms. I can safely say that people who are suited, booted, and in their like brogues and really tight, smart shoes are often the patients that I tend to see who come in with Mortons Neuroma.
Or when you've got ladies that are wearing really high heels.
Absolutely, yes.
A lot of stress here. That can lead to it. The symptoms, I mean, generally with Mortons Neuroma, you'll get it just in between the metatarsals. You'll get this burning, sharp pain, shooting pain. That picture that you see there is not a classical site of a Mortons Neuroma. That's in the second and third. Normally, it's between the third and the fourth. But, Tosif, me and you still wouldn't use generally injection of the first line treatment. Now, what do you tend to do for the Mortons, for if a patient presented with forefoot pain, they've got this sharp, they've got electric shots shooting up. After you've diagnosed them and you've gone through all the different things that it can be, and you've thought, okay, so Mortons Neuroma, what's the first line treatment?
So typically for me, it just initially I look at their function, I look at their footwear, I look at what's basically diagnose it. Footwear modification, footwear changes is one of the key one and one of the main ones. Orthotic therapy is highly effective when it comes to Mortons Neuroma, especially early stages. You can manage that quite well. Usually that's more than enough to manage the symptoms as well as prevent it from a long-term sort of problem with regards to Mortons Neuroma. However, steroid injections tend to do a really good job of it if neuroma is enlarged and cannot be managed by just footwear and orthotics. Do you do anything?
So I would do very similar to you. I would add in an extra thing though. So I would definitely change footwear. I would almost definitely recommend orthotics, and I think just raising up the underneath the neuroma and maybe a pad just to offload it is great. I would also look at the calf muscles. If the calf muscles were very tight, I may give calf stretches. However, I like high volume image guided injections for a Mortons Neuroma, for a steroid injection, because you can actually see the needle going into the neuroma and you just blast it away, and it's almost instantaneous. But it's, as Tosif said, it's not my first line of treatment. Sorry, I interrupted you while you were talking.
No, I don't do the high volume, but for me, steroid injection does do a very decent job of.
Let's move to the next one, which is plantar fascia injections. Hey, heel pain. Okay, let me go. We can do another video on heel pain alone, and I think me and Tosif will, because it's something that we see a lot of. There are many different causes of heel pain. Plantar fasciitis, plantar fasciitis is one of them. But generally speaking, the classical symptoms you will get is you'll get intense pain when you first wake up in the morning and after periods of rest. But that will calm down, and it'll be a sharp shooting pain that will start where that green dot is actually. Oh, I've just moved it. Where that green dot is, and then it will shoot up to your arch as well. There are many different treatments for plantar fasciitis. On the left-hand side of the screen, you'll see shockwave. PRP, there isn't a great amount of evidence for PRP for plantar fasciitis, but well, there's like a growing evidence base on it. I think it's more suited if it is chronic and it's been going for a couple of years and you've tried other treatment modalities and including other treatment options, including injections, and it hasn't been effective. Steroid is the go-to, and I think there's a lot of evidence regarding it, even though some of, like in the past couple of years, we've had mixed evidence, but I still think there's a great deal of evidence. And from speaking to yourself and other practitioners that do a lot of plantar fasciitis injections, anecdotally, we've had great results from it. And prolotherapy is like a mixture of glucose and local anesthetic. But so see, if it's not our first, it's not our first line of treatment, is it?
Not at all. With anything, I think any treatment, we start off with conservative management, of course. After assessing and diagnosing with the plantar fasciopathy, we often follow the strengthening rehabilitation program, orthotics for the comfort and pain relief, self-management of patients, footwear modification. All these things come before we think about steroid injections or any injections. Shockwave therapy is proving to be, again, there is a growing evidence with regards to the shockwave therapy and the heel pain and plantar fasciopathy. Steroid injections, when would I do them, and what sort of stage that I personally do them in the heel pain patients? If I've tried the exercises and they've got orthotics and they're progressing with these things and they're not making any improvements, or if the pain is so severe that they're unable to kind of walk and they're unable to do the exercises, they're unable to perform the rehabilitation plan that we've actually set for them, that's when I usually come in with a steroid injection, and that provides a really nice buffer in terms of pain reduction, allowing them to do the rehabilitation, getting on with the rehabilitation process. I always explain to the patients that it is not the treatment, it is aiding your rehabilitation process for your plantar fasciopathy. And yeah, I've had great success with it. There are some, I was going to ask you that there is some evidence. For me, it's really old evidence to say that steroid injections can cause ruptures and side effects for the plantar fasciopathy. What's your take on it?
I have done thousands of plantar fasciitis, plantar fasciosis injections, steroid injections. I've yet to have somebody rupture on me. I haven't had any side effects, touch wood.
Touch wood, I haven't had any side effects. No.
I would say this, okay, so if a patient comes to me and they are unable to either do the activity that they want to do, or they are unable to work without being in excruciating pain, I may combine orthotics and rehabilitation and a steroid injection straight away, rather than going through it incrementally. And I'll tell you why. So I have like a heel pain, like pyramid. I always say that all three stages, all three sides of this pyramid are equal. Rehabilitation is my foundation that everybody, as you know, and you do the same, everybody gets rehab. Almost everybody gets orthotics, and the orthotics are enables. Sorry, I've just got something.
I've got the same.
It's been we'll run out of time soon, so we'll have to restart it in a minute. Orthotics are a basic, are something that I think I recommend to most people, and steroid injections or an injection therapy. But shockwave treatment can be highly effective for this. What I'm going to do is...
Sorry to interrupt, that mostly the previous evidence which I came across with regards to shockwave was on chronic, but I think there is some more, there's some more evidence coming with regards to the acute cases of plantar fasciopathy as well.
It does, I mean, it's very effective, but I don't think you need 3 sessions. I think in my experience, I do shockwave, you need 6-7 sessions for it to be effective. So that means you need to come for 6-7 weeks. Some patients are fine with that. Other patients, if they've got a busy lifestyle, they're not going to be so fine. I think we're going to run out of the time on Zoom. So what we'll do is, I'll stop it here. We'll carry on doing it. I'll stop the video here and then we'll come back to it in a minute.
Abid, I think they've just said that they upgraded it, so that means that we can carry on until it stops.
Hey, there
Yeah.
you go. Yeah, learn something. This is a new COVID-19 world. We're having to talk. I can't even see my friend. I have to talk to him virtually with these handsome good looks. All right. Sinus tarsi and ankle impingement. This is so interesting. Absolutely so interesting. Something that we see a lot of. This is my patient's foot. The pain will be on the outside of the ankle, and there'll be a chronic, it'll be very difficult, especially when they're doing certain movements. Ankle impingement often occurs to footballers. So a footballer that's kicking the ball constantly kicking the ball, I might send them off to have an MRI, and we might find that there is osteochondral defects. So there might be areas of the talus that are causing an ankle impingement. I don't know if you do a lot of ankle injections, or Steve.
Sinus tarsi injections for me predominantly was for my rheumatology patients. For rheumatology patients, the way it actually went on is that rheumatoid arthritis leads to acquired adult flat foot deformity, meaning that the feet becomes like, over the time, they just keep becoming flatter and flatter and flatter. So that leads to like the lateral impingement of the ankle. And I quite like these injections because they're very successful. Because as soon as you've injected a decent amount of volume in there, that's it. It just opens up that area.
Yeah,
it just opens up that area, and it's very rewarding injection for me, basically, because you've done it and it gives good results, and patients absolutely love it, and they can get on with doing the things that they need to do.
Let me add a proviso, and I'm sure Tosif will also agree with me. As with everything else, I would probably give orthotics with a heel raise. Normally about 6-7 mil. Actually, I'm quite high because you want to try and allow the ankle a bit more movement. That works well. But I would completely agree with Tosif. It's a very simple injection to do, and it has a very high success rate. Obviously, there'll be the odd patient that it won't work. I have like a 95% success rate with this. And I'm a big fan of high volume injections, so I tend to do really high volume injection with this. My steroid of choice tends to be dipomedrone, but I have done Kenalog with a patient-specific directive for it. I've done Trumial, and I've done chlorotherapy for this as well. I actually think it doesn't matter what I inject into here, as long as
I think even if I inject LA, because I have injected LA as well in that space. What I was going to say is that orthotics that you mentioned is a really good option. What I found in my specific patients, is that they weren't very good at tolerating the orthotic, or we call these devices as it's gone out of my head. You have accommodative devices, and then you have functional devices. So the functional devices, they just cannot accommodate. So for me, often this can be like a very early on sort of therapy that I tend to use for my patients.
I think this would depend upon the demographic. So if you were treating an older patient who's a rheumatoid arthritic patient, they would struggle with a functional orthotic. Yeah. My demographic tends to be, I see a lot of footballers, for example. They almost always get an orthotic with a heel raise, and they get this injection, and then I try and get them out of the orthotic slowly. So it's not, and Tosif would say the same thing, I'm sure. An orthotic generally is not for life, apart from a narrow band of patients. Right? There are a narrow band of patients for a variety of different reasons, structural problems generally, or they've got like neurological problems that have to constantly wear them. But generally speaking, an orthotic is not a magic bullet, nor is an injection. Everything is combined. But I'm sure you would agree with me on that.
Yeah, absolutely. I think some of, again, coming back to rheumatoid arthritis, again, is that if they have a condition like rheumatoid arthritis, which is not going to improve, or which is not going to completely heal, they will need that continuous support for the rest of their life. But for most of my active patients, if I use an orthotic therapy to aid with my treatment plan, it's very much short-lived. As soon as we're good to go and they're pain-free, we tend to remove the orthotics and let them carry on with it.
Cool. Let's move on to the next one. Peroneal tendinopathy. Something we see a lot of. Ashley just made a video that I'm going to release next week about ankle sprains and rehab, 4 stages of rehab, which Tarsif is going to share on his page. But ankle sprains.
What you produce is little gems, not just for the patients, for the podiatrists as well. And I think we all learn from you. So I'd be more than happy to do that.
So a lot of patients, let me come back. So if you sprain your ankle, it goes over like that, as you can see. And the mechanism of injury is generally like that. You get a lot of swelling and pain on the outside of the ankle. What can happen? I mean, there's a lot of structures here that we are not going to speak about, because that's another video that me and Tarsif are going to do about lateral ankle instability, which I'm going to force you to do. But one of the things that can happen is peroneal tendinopathy. Now, you've got 2 peroneal muscles, tendons that attach. Sometimes they get damaged after an ankle sprain, or if you've got either very high arched feet or very flat feet. The first thing that we do is not an injection, is it, Tarsif? What's the first thing that we do?
With tendinopathies, I'm a lot more cautious, and I'm a lot more careful when it comes to doing the injections for the tendinopathies, be it peroneal tendinopathy, be it Achilles tendinopathy, or posterior tibial tendinopathies. Generally, I think a rehab works really, really well for the tendinopathy.
What kind of rehab would you first do for a peroneal tendinopathy?
So in terms of the loading is absolutely necessary.
Can you explain to those that don't know what loading is? What's loading?
So loading is when you actually move the tendon. So you put the weight through the tendon is what the loading is. Okay. There are different types of loading, and early on I probably will use isometric loading, where you're not moving the tendon, but you are putting the weight through.
Give me an example of an isometric tendon holding like load.
So a fairly simple one would be if you basically press against the wall and just hold it there, or as like E version of the foot, or like outside. Yeah. So that would be my, if the tendon is painful. But if tendon can actually tolerate the movement, I start off with the eccentric, which is the lengthening of the tendon. That would be my first line. And then I would basically get onto the lengthening and the shortening, eccentric and concentric, and then as we move further to that.
So, I mean, for me, as Tarsif said,
orthotic therapy to offload the tendon to allow it to heal, basically.
So for me, as Tarsif said, rehab is probably my first line of what I always do. I tend to, my like approach differs slightly to that, and it depends on what stage they come to me. So it depends on where they are, how long has it been since their ankle sprain, and what their current function is, and what they want to get to. So if they just want to walk, there's certain things. If they want to run or play a sport, I'm focusing on different types of loading movement. Orthotics, we give insoles that have got a wedge on the outside of the heel and outside of the forefoot to try and alleviate some pressure. Now, that being said, I do a lot of injections for peroneal tendinopathy and for lateral ankle instability, depending on what is damaged. I always do them ultrasound guided, and it's always not my initial plan. It's always later on that I do it. Unlike plantar fasciosis, heel pain, I'm I may give an injection depending on their symptoms as an initial treatment, but I very rarely do it for peroneal tendinopathy. But I find that a very small amount of injection, because you can get tenosynovitis.
That's what I'm going to come to, is that when you're injecting, the aim is to kind of inject the tendon sheath, and to be able to get there blindly is really, really difficult.
Not doing it.
And the evidence with regards to tendon ruptures, with the steroid especially, is there. So hence why when I think about injecting the tendons, it's important that you do it guided with an ultrasound, so you know exactly where you are. And depositing, I suppose, depositing in tendon sheath improves that, improves the outcome.
It actually moves. I tend, to be fair, I tend to use Zeal and chlorotherapy a lot more for lateral ankle injection, and that's just a preferential thing. It's not. I'm not saying it's right or wrong. I just find in my hands, Zeal is more effective, which is like a homeopathic herbal injection. Very effective. It can have the same. It has the same therapeutic outcome as a steroid injection, but with far less possible side effects, which is why I'm a great advocate of it. Is there anything that we need? Is there anything else that we need to speak about regarding peroneal?
I think osteoneal tendon is another a good one. I know that you probably aren't a big fan of it, but I think that quite helps with the shock absorbance and lubrication of the tendon. So again, it's a new phenomena, and there's more research coming on it, but I quite like that.
Okay, so next one. Posterior tibial dysfunction. Now, you can see, this is something that we see a lot of. Now, that gentleman is pointing to where the discomfort is, or where the posterior tibial tendon runs. The posterior tibial tendon is a very powerful tendon. You would often get pain around there, moving into the arch. So where the end of that red line is, and that yellow line is. So you can see that it's marked out with the anatomy is marked out there. As with everything else that we've spoken about, it's not the first line treatment. Orthotics and rehab are always the first line treatment for posterior tibial dysfunction. Injection treatment is an option in the right hands. Now, if any patient is watching this, you make sure you choose the podiatrist very carefully who's going to do this injection. There's only a few of us, well, not a few of us, but there's not many podiatrists that can really do this well, in my experience. Okay, I'm not casting aspersions on my fellow colleagues, but I know this is a very difficult injection to do. Do you have any? I mean, I'm sure you would agree with me, but is there anything else that you want to add?
Well, yeah, I think it's a very difficult injection, and has to be done as ultrasound guided injection. And it's you want to be seeing a person who has experience in doing these sort of injections rather than anybody and everybody. We talked about orthotics, and when would you use the orthotics for a bit more as a long-term thing? And tib post patients are one of the key candidates who tend to require that for a long term as an orthotic.
Yeah. Although that being said, I try, unless there's a tear in the tendon, unless there's an intrasubstance tear, because with the intrasubstance tear, I have with a patient-specific directive used glucose mixed with local anesthetic and tried to inject it into the tendon, and I've had great results. But rehab for this is so important. Getting that tendon stronger is really important, but orthotics as a long-term treatment option for this is quite essential, actually.
Yeah, it depends on the stages that the condition is at. If it's early stages of 1 or 2 and the patient is a younger patient, they tend to recover quite well, and they can get their rehab done, and they strengthen the A tendon, and they're absolutely fine. But patients who have stage 3 and 4, it's like stage 4 is like way advanced.
I mean, normally when they're at stage 4, which basically, if you're listening and you don't understand what these stages mean, it means how bad it is. There is a place for using an ankle brace at this stage to give you a bit more. I find that injection treatment option gives you a window of opportunity for rehab in the early stages. For latter stages, I'm not quite sure. This is where the clinical judgment is very important. I tend not to inject these very often. I'll do one a year, and I'm very conservative, very conservative about injecting this as opposed to some of my other injections. Let's move on to the next one. Tarsal tunnel syndrome. Okay.
That's your favorite one.
I do a lot of tarsal tunnel syndrome. You get sharp shooting pains into your arch of your foot, into the heel. It's often misdiagnosed as plantar fasciitis. But if you go to a podiatrist who knows how to assess you, they'll be able to assess you, and a tarsal tunnel syndrome is something that responds very well to an injection. Do you have any comments on that, Tosif?
No, yeah, absolutely. A similar experience for me as well. That it responds really well to, along with other treatment modalities, as we talked about for all the other conditions. For me, injection does a fairly good job of it.
For me, tarsal tunnel syndrome, I don't even give orthotics generally, because I know it's a temporary nerve irritation.
Yeah.
Unless they've got flat feet. So unless the reason why they've got tarsal tunnel syndrome, so it's like trying to. So with like podiatrists, we sometimes are like detectives, which we're actually trying to find out why that happened, rather than just treat the thing that happened. So if the problem is, if the reason why the nerve's irritated is because you've got flat feet, or is it because of the way you're running or walking, there's an issue going on in your hips or your knees. So we're looking at you from top to bottom and trying to see, okay, can we change some musculature further up that will affect the tarsal tunnel? I often say this to patients, that poor feet tend to be the weakest part of a chain, but the problem in the chain will be somewhere else, and the feet get affected. And this can be one of the things with any kind of nerve problem, and tarsal tunnel syndrome obviously happens a lot.
Well, on a lighter note, you talked about that podiatrists are detectives. I had a patient of mine who came in, and I think they had plantar fasciopathy or something, and we were talking, and I'm asking them questions after questions, and they said to me that they said, Tosif, you are like a detective. And I said, am I? And yes, you are like a detective, and a particular one. And I said, which one? And they said, Colombo.
Which one did they call you?
You're like Colombo because
Colombo.
You question.
They could have chosen any detective. They chose Colombo.
I said I would have preferred James Bond.
James Bond's not a detective. He's a secret agent. Okay, I like Sherlock Holmes. Okay, mid-portion Achilles tendinopathy. So, Mr. Tosif, you have done this injection with me. You've assisted me, and the video is out there, and it's viral. We've had millions of views on it. This is something I do a lot of. It's something that is now got a great deal of evidence. So, mid-portion Achilles tendinopathy, I'm just going to move this back. You'll get pain in your Achilles tendon, and it's halfway. Let me see if you can see my foot, just there. It's particularly bad when you first wake up in the morning, and when you're walking down the steps. It's very, very important you get diagnosed. Make sure you don't have a tear there. If you have a tear there, there is other things you can do. Mm-hmm. With mid-portion Achilles tendinopathy, there's 3 options. Orthotics, everybody gets. Mm-hmm. After that, shockwave or injection therapy. Most people only do shockwave, okay? Shockwave can be very painful for mid-portion Achilles tendinopathy. What we're doing with mid-portion Achilles tendinopathy is we're injecting 40 mil of injectable saline, 9 mil of Marcaine, and 20 milligrams of dipamedrone injected using ultrasound into the Kager's fat pad. And the idea of this injection is to get rid of the neovascularization that sits within the Kager's fat pad. That allows it to heal. There's some really good evidence regarding Otto Chan. We've got some level 1 evidence regarding Bolzian. There's done 2 studies on it, double-blind studies which compared it to PRP and to sham treatments, and they're brilliant. It is favorable. But what I missed out earlier, and I think Tosif's looking at me quite angrily, is I should have mentioned rehab. Rehabilitation, stretching, and strengthening, eccentric below a step, and fast movements are very beneficial for mid-portion Achilles tendinopathy. Before I speak a bit more about this injection, what's your views on mid-portion Achilles tendinopathy?
Well, what I wanted to ask you is that you talked about the level 1 studies for the high volume injections. You've been doing them. I came to your clinic and I've assisted you with one. You've been doing them for a little while. What's your personal experience with them?
So I've done many injections, and I don't think I've had one fail on me. So I tend not to do this for patients that have just initially got Achilles tendinopathy. I will always give them orthotics and exercises. However, if they are not getting better, or if they're an elite athlete, which I see a lot of, and they are preparing for a specific event, then I may shortcut the rehab and I may go to this. The injection is brilliant as long as they follow my 10 days rehab program that I write down for them post-injection. For the first 2 or 3 days, they're doing very little. And then after that, they start a progressive rehabilitation program. And normally 10 to 12 days, they get back to doing the activity that they like to do. This is also something that needs to, this injection is a very difficult injection. It needs to be done by individuals that have a little bit of experience with them. But that's my experience with high volume injections. What's your experience with, you helped me. How did you get on with that injection?
Yeah, I found that by personal, looking at what we're actually injecting, normal saline, which doesn't really have a lot of any side effects. Marcaine as LA, again, dipamedrone is so the important thing here is that we're not injecting into the tendon, not in the tendon.
And the Kager's fat. That guy that me and you did, he had mid-portion Achilles tendinopathy for 8 years. 8 years. We gave him that injection. 12 days after that injection, he was running around. No pain in his. That's amazing. And I've got loads of stories like that of patients who've had mid-portion Achilles tendinopathy for a long time. And it can be highly effective if done with the right person, and also if diagnostically you are 100% sure it is mid-portion Achilles tendinopathy.
And that's where ultrasound comes in to have that ability to be able to confirm that diagnosis. So you're not physically just looking at going by the history and subjective and objective assessment. You're looking at it with an ultrasound, and you can just confirm the diagnosis, can't you?
We are gonna, me and you are gonna make a video about this at some stage, because this is something that athletes see. We see a lot of athletes with this, and we should make a video in depth talking about mid-portion Achilles tendinopathy. I won't spoil that video too much, but one of the things that you need to watch out for is you can have bulging of the mid-portion of the Achilles tendon, but you can have an intrasubstance tear at the same time, or you could have an inflamed bursa. But it gets very complicated. But if you generally have mid-portion Achilles tendinopathy, orthotics, rehab, first line, second line, shockwave, or high volume injection. In my experience, I like high volume injections, and I think they can be highly effective. Let's move on to the next one. This is something very difficult, and I'm sure Tosif will agree with me. Insertional Achilles tendinopathy. This is when you get pain right at the bottom here. Often misdiagnosed as plantar fasciitis, very difficult to treat, very difficult to rehab, and it's when it comes to our clinic, by the time they've come to me and Tarsif, they've had it for a little while because people just ignore it, and it's chronic now. It's not in the first stages. Have you? I mean, I have injected this. Have you ever injected this?
I haven't injected it. A friend of mine who is a physiotherapist, he used to inject them, but I haven't personally injected it. Given that the location of the tendinopathy and the space available there is very small, and the accuracy that you need to hit is quite high. So it's not an easy injection, as you said, to do. And again, as this is not my first line therapy as a treatment, I would rely on conservative management before I would think about that. Common my go-to treatment option for insertional anyway.
I have injected it. It's not my first line treatment. I try and avoid it. The people that I have injected, I have had a great deal of success with it. I may use steroid, but I won't go into the tendon. I'll be injecting behind the tendon. Sometimes I use a different therapeutic option. But yeah, you are right. It is a difficult injection to do. It's always ultrasound guided. Never ever done this blind. It's a very difficult option to do. Final thoughts. We have come. I don't know how long we've been speaking for now. Doesn't time fly when you're having fun?
It's probably been like 45 minutes.
Hey, 45 minutes of mine and Tarsal.
Good luck with the editing, Abid.
We're not editing nothing. This is the way we're doing it. Final thoughts. Okay. PRP. I do PRP. Do you do PRP?
I don't. I'm again. This is something which I wanted to discuss with yourselves. That I was thinking to do the course this summer for PRP, but with this COVID-19, I don't think I'm going to be able to do it, and I'm going to prioritize our independent prescription as opposed to the PRP. But the results are encouraging. The research coming up with PRP for intra-articular, especially inside the joint, is looking good. I think it's the issues come with PRP is that the equipment required, that's fairly expensive, and then taking the blood. That's one of my biggest bugbear is that.
So, let me just explain to people, because you might be thinking what Tarsif's talking about. Now, with PRP, it's called platelet-rich plasma treatment.
Yeah.
What we do is we take blood from the patient, carefully, gently, and we put that into a special test tube, and that is used. Then we spin that in a centrifuge for 10 to 15 minutes. We then take that out, and then we remove the poor plasma, and then we remove the platelet-rich plasma, and we inject that in to the injured site. Now, I use PRP for a variety of different things, and I have a great deal of success with it. So I use it for knee injections a lot, because if you're a member of the IOCP, you can do knee injections, and I have used it for tendinopathies. I think it's the safest thing to inject into a tendon, actually.
From the safety point of view, I think it is very safe. I think what stopped me is the ability to do the course. I am a SOCAP member, College of Podiatry member, so I don't think I'll be insured straight away. So
then you need to see the light. You need to see the light and move away, which is what I did after 15 years.
That's a stumbling block for me.
Stumbling block. Look, I went to a couple of courses to learn how to take blood, so I'm really comfortable with taking blood now, and it's something that I find a really useful option. Okay, so it's not necessarily I use it with every patient, but we're like people with a toolbox. We have a large toolbox. We have many tools within that toolbox, and it's dependent upon what we need. Prolotherapy is a mixture of glucose with local anesthetic. There's some great results There's been some great studies done on plantar fasciitis, heel pain, and prolotherapy injections. There's been a great paper done on knee osteoarthritis and the use of prolotherapy injections. Really safe unless you're a diabetic, because then we wouldn't do it to you. Biotherapeutic Zeal and Guna, great. Durolane, I don't use, but I know some other people that use it. Knee injections, I do a lot of. I know you don't do it yet, but as I said, I'm going to convert you to IOCP. I'm working on it very slowly. Do we have any other final thoughts regarding injection treatment?
No, I think we've covered pretty much in depth with regards to the conditions we treat with injections and the type of injections we use. And it's very specific and individual to every individual patient that we see, who is suitable, when is it suitable for them, rather than doing it blindly, I would say. So yeah, I think it's been a good talk.
Well, thank you very much for, this is our first video, by the way, that we're going to make live. We're going to make many more videos because we're in lockdown and we got nothing better to do with our lives than educate people about certain things. We should call this TV program something. We should give it a name. Like we should give it like the two Ronnies, or Little and Large, or the two handsome Asian men, Asian podiatrists. We should call it a name.
Sherlock, for me, Sherlock.
Columbo and Sherlock. Sherlock and Columbo. But yeah, I hope those that have watched this have found it useful. If you have any questions, drop wherever this is being placed, because it's going to be on my Facebook page and Tarsi's Facebook page. Drop us a message on Facebook, Instagram, LinkedIn, wherever you find us, and ask us a question. I mean, look, we're very open regarding advice. You know, we don't mind giving out advice. We're not going to charge you for advice via email or message. Tarsif might, because he's like £1 million car and yacht and aeroplane that he's got to maintain. Don't you, Tarsif?
Of course I do. They have to be paid one way or another, didn't they?
Okay, thank you very much. I'm going to stop the screen share. Oh, there you go. And I'm going to stop the recording. Thank you. Hey, how was